Today's discussion is going to focus on the disproportionate impacts of this pandemic on low-income communities, especially those of color. I want to thank those of you who were on our first virtual roundtable a couple of weeks ago for the very enthusiastic response that you gave us either directly during the session or afterwards through emails. And we're really pleased that we've had a great cross-section of members participating with expertise in all areas of social insurance. Our goal is to provide a platform for meaningful conversations about the importance of our social insurance infrastructure, especially during times of catastrophe such as this. I hope that all of you have been able to hold up well. We have heard from many of you, as well as funders of the Academy, that now more than ever, the vital role of social insurance in providing economic and health security to our people needs to be reinforced. And that is clearly what we intend to do. Whenever we read stories about what is happening to our country, I know one of the first things I ask is, how can we even imagine how much worse it would be without programs like Social Security, unemployment insurance, Medicare, Medicaid, family medical leave, workers' comp. In other words, all of the core elements of our social insurance infrastructure. We realize that this pandemic shines a much needed spotlight, not only on what social insurance does, but it raises issues about how much more social insurance could do to address the issues that we are now facing. So I want to invite all of you to offer your expertise, your insights, so that we can do our work and involve you more in it. So please keep those suggestions coming. They will help us form further virtual roundtable agendas. We have 60 minutes today. We want to make the most of it. We clearly will not be able to discuss all the facets of the issues we're covering, but I want to give you a heads up that based on your feedback, our next roundtable, which is Tuesday, May 5th, we're trying to do this every other Tuesday, will focus on the key impacts and needed resources for people with disabilities who have been extra affected by COVID-19. Now, I want to tell you how you can participate in today's dialogue. For those of you who are Zoom veterans, you know there are two ways to participate in a Zoom session. There's the chat box and the Q&A box. If you have questions for everyone that you would just like to interact with all of the participants, then on the chat feature, make sure that you have indicated that recipients of your chat are all panelists and attendees. If you don't do that, then just the panelists will have the benefit of your interaction. And then if you want to pose specific questions, use the Q&A box, and I'll try to facilitate those with our moderator. The session is being recorded. The roundtable recording will be available for everyone who registered and all Academy members. And when the webinar ends, we hope to continue the discussion on our website. We have a new section devoted to COVID-19, which we are populating with resources both within the Academy and from other sources. So please, if there are certain items that come to your attention on COVID-19, you want us to add them to the resource page, again, send us an email and we'll try to do that. Also, at the end of this session, you'll be getting an instant survey. Please fill it out right away if you would. That'll help guide us with future virtual roundtables and also help to smooth them out as we go forward. So with that, I'm going to introduce Helene Olin. Helene has been kind enough to accept our invitation to moderate. Helene writes a fascinating regular column at the Washington Post, which I encourage all of you to read, and it delves into all aspects of this pandemic and also looking at the related issues. So without further delay, I'm going to ask Helene to then introduce our other panelists. Helene?
Hi, good afternoon. Once again, let me welcome you to the National Academy of Social Insurance's ongoing webinar series on the impacts of coronavirus. Up for discussion today, COVID-19 and the needs of lower income people and people of color. There's little question the low income have suffered disproportionately during the current pandemic. Many of the jobs they hold, think hospitality, think travel and tourism, think retail, think restaurants, and I mean everyone from fast food workers to dishwashers at 4-star Michelin restaurants, were among the first to suffer layoffs. State unemployment systems, including in New York where I live, still can't keep up with the demand and continue to crash. There are conflicting guidelines for gig workers. The undocumented, in many cases, can't access benefits at all. And then there is another issue, the jobs they continue to hold. In many cases, they are suddenly much appreciated, but still relentlessly underpaid frontline workers, grocery store clerks, nursing home aides, warehouse workers. How are we taking care of them? What problems are they facing? And what can we do to make things better? Here to help us discuss all this is Indi Duda Gupta, the co-executive director of the Georgetown University Center on Poverty and Inequality, where he leads work to develop and advance ideas for reducing domestic poverty and economic inequality, with particular attention to gender and racial equity. He serves on NAEYS's board of directors. And Sarah Rosenbaum, the Harold and Jane Hirsch Professor of Health Law and the founding chair of the Department of Health Policy at the Milken Institute School of Public Health at George Washington University. She's an expert on Medicaid, Medicare, and private health insurance. Indi's going to speak on social assistance and paid leave, something that is incredibly important since, of course, many frontline workers, again, in places like grocery stores and online warehouses, are reporting difficulties accessing it. Sarah is going to speak on Medicaid and health equity, an issue I admit I feel very keenly here in New York City, where the public hospitals, where most of the Medicaid patients have turned for treatment, are the ones that appear to be most overwhelmed by the impact of COVID-19. Indi, would you like to take it away?
Sure. Thank you, Elaine. I'll assume folks can hear me unless I see something in the chat telling me otherwise. Let me just say that I want to talk a little about the disproportionate impacts that we're seeing, a bit about unemployment insurance. I know that's been covered in more detail in a prior webinar by the Academy, a bit about cash assistance, housing, and then food assistance and paid leave, as Elaine mentioned. So first, the disproportionate impacts. It's quite clear from early data that the COVID-19 crisis is hitting marginalized communities particularly hard. So Urban Institute data, for example, suggests in one regional analysis that residents of majority Black counties have 3 times the rate of infection and almost 6 times the rate of death as residents of majority white counties. The data from the state of Louisiana suggests that African Americans are 32%, while African Americans are 32% of the state's population, they're actually experiencing 70% of the state's COVID-19 deaths. Recent data from the Navajo Department of Health suggests that Navajos are suffering fatalities at twice the national per capita rate. And more broadly, some of this will be discussed more, I'm sure, by Sarah, but folks who are lower income, Black, Indigenous, Latinx, typically have less access to healthcare resources and supports and are more likely to have underlying health conditions. For example, almost 2 in 10 Latinx people before the crisis hit, and 2 in 10 Native Americans or American Indians, and 1 in 10 African Americans didn't have health insurance. Communities of color are also among the most likely to breathe polluted air, and even small increases in pollution seem to be associated with statistically significant associations with mortality from COVID-19. And increased exposure to pollution, chronic lung, increases the risk of chronic lung conditions and can exacerbate pre-existing asthma, which right now still seem to be risk factors for severe illness from COVID-19. And then finally, on the disproportionate impacts, let's remember low-paid workers, by and large, can't take time off in the same way that others can and are more likely to be on the front lines, as Elaine just explained. So some of the data indicate that Black and Latinx workers are much less likely to be able to telework, that even before the COVID-19 pandemic, according to the Center for Economic Policy Research, more than 30 million workers were employed in 6 broad industries that are now on the front lines of response. The industries as defined by New York City Comptroller include grocery, convenience and drugstores, public transit, trucking, warehouse and postal service, building cleaning services, healthcare, childcare, and social services. And the analysis suggests that almost 2/3 of these frontline jobs are held by women. And the New York Times similarly analyzed the data and found that 1 in 3 jobs held by women are designated as essential. So there are some gender, racial, and economic equity concerns throughout this crisis. Let's talk briefly about unemployment insurance, and I'm happy to answer questions at the end about this or anything else. But we saw essentially in the last 4 weeks a record 20 million people file for unemployment insurance. To put in perspective, we lost fewer than 9 million jobs during the entire aftermath of the 2008 financial crisis. The data suggests that these job losses this time around have disproportionately been by women so far. And Congress did act in a meaningful way with significant temporary improvements to our system of unemployment protections, including more money through pandemic unemployment compensation, that's $600 a week for unemployment insurance beneficiaries, in addition to whatever else they might have gotten. An extra 13 weeks of unemployment insurance through pandemic extended unemployment compensation, or PEUC, for folks exhausting state benefits, and up to 39 weeks of a new pandemic unemployment assistance program to reach more workers who were previously ineligible for unemployment insurance, including some folks who are self-employed in the so-called gig economy, and others who may have been ineligible for state UI programs. And it also includes some workers who started a job or were about to start a job, but for COVID-19, unfortunately right now fairly narrowly defined, would be working. These participants in the new PUA, Pandemic Unemployment Assistance Program, can also benefit from the PUC, or $600 increase, the pandemic unemployment compensation. Helene mentioned some of the cash payments, $1,200 per adult, $500 per child, but it phases out starting at $75K for individual filers and double that for 2 adult filers, so long as you have a Social Security number. And the children are defined as under 17 using a restrictive child tax credit definition. So this is going to be a challenge for a lot of folks who might expect to get payments but won't. First of all, now is really not the time, if you couldn't before, to be able to set up a bank account to cash a check. So for some folks who are unbanked or underbanked, it's going to be a challenge. Immigrants who file with an ITIN, individual tax identification number, are going to be left out. This is a real consequence. I mean, I just heard from a friend in New Jersey who's talking about how folks are back out on seeking out day labor, because they're not getting support through any other way. That's not great for our public health that we fail to support them. And millions of college students are going to be claimed as dependents, but too old to count towards their family's recovery rebate, as well as other adult dependents, including adults with disabilities who are being left out. So let's do a quick whirlwind of housing. So as folks may know, many families and individuals with low incomes lack the resources and space to safely shelter, including, of course, people who experience just unstable housing and homelessness, but also people in group quarters and people in unsafe housing. Their estimates are tricky for homelessness, but an estimated 500,000 folks were experiencing that before the crisis hit. But then you've got about 1 in 5 folks living in sort of at least 3-generation households. And that can sometimes be challenging just with regard to space. According to some of the most recent data, about 1/3 of parents with low incomes faced housing hardships, such as eviction or inability to pay rent. So then we also have data on folks in institutional group quarters, around 4 million. That includes correctional facilities and nursing homes. And the CARES Act did have some policies to help address these crises. So there was over $12 million for HUD. And at the federal level, there was also an eviction moratorium, but only for folks who live in properties that have federally backed mortgages. The Urban Institute estimates, we're talking about 1 in 4 rental units here. Some localities are obviously doing much more, but that moratorium can help some people with money going out the door for up to 120 days where there can be no evictions, and then also there's other protections to promote forbearance for 90 days. There's also some mortgage relief, including, again, only for folks with federally backed mortgages, but that's actually a large share of outstanding mortgage holders. And that's for 60 days where there's no foreclosures allowed after March 18th. And limiting of other processes that would essentially remove people from their homes. And then food assistance. Here's a major area getting attention now for a potential fourth package, not necessarily the sort of 3.5 package people are hearing about now. There were some important measures in the sort of second and third response to COVID-19, including pandemic SNAP, where families can get additional SNAP for kids who are no longer getting the school meals they might have otherwise gotten, and then increasing increasing monthly benefits to the maximum allowed. Importantly, we have not increased maximum SNAP benefits or done as much as some might like to get more people into the program, but there are still a lot of provisions in the CARES Act and Families First Coronavirus Response Act that would make it easier and more streamlined for people, including by suspending some of the work reporting requirements and time limits. So hopefully more folks can get into SNAP. There's also additional assistance, something we should think about, of course, beyond the 50 states and DC for Puerto Rico, American Samoa, Northern Mariana Islands. Similarly, the Pandemic Unemployment Assistance Program applies beyond Puerto Rico and the U.S. Virgin Islands, which is really the first time, to my knowledge, for unemployment assistance. And then paid leave, just to give a quick overview here. On the one hand, this is an important precedent. You'll see that sort of throughout a lot of the provisions. We have set a lot of historic precedents despite the lack of any permanent structural changes by and large. The precedent here is for the first time. We have federally required paid leave, paid sick days first, and then paid leave. It's about 80 hours of sick time for COVID-19 related reasons, again, so very narrowly defined, but you get full wage replacement for those 80 hours if you're eligible, and then up to 10 weeks specifically for folks who have unmet childcare needs due to COVID-19 at 2/3 wage replacement. All employees of covered employers are eligible for 2 weeks of the paid sick time. That's the 80 hours. And then employees employed for at least 30 days are eligible for the up to 10 weeks. There are important exceptions for essential workers, and a recent analysis by our friends at the Center for American Progress estimate that actually 68 million to 106 million private sector workers will be excluded from paid leave protections. Partly there's an exemption for workers in businesses with more than 500 employees, and then there's an exemption for the if there's an exemption for the essential workers as well, but there's a lot of freedom for the employers to determine who's essential here. Let me stop there and pass it back to Megan.
Hello. Should I just proceed? I guess so. Hi, everybody. Sarah Rosenbaum here from GW. Indy did, of course, a great overview of poverty and its effects on health and welfare. So I'm going to plunge in on Medicaid provisions that have been enacted to date. Obviously, these provisions get layered onto a very complicated program to begin with that already did some of the things that would need to happen to deal with the pandemic, because Medicaid coverage is very comprehensive. But there were a lot of holes in Medicaid, and of course some of those holes are just from the natural structure of the program, the flexibilities it gives states. But the biggest worst hole, which I'm sure all the listeners by now are aware of, is the failure to cover poor people up to the levels contemplated under the Affordable Care Act. So let me march through quickly the things that the various COVID bills have done. The big one for our purposes is the FFCRA, the Families First Coronavirus Response Act. That has really is the centerpiece of the Medicaid provisions. The CARES Act makes some technical corrections. The first stimulus bill does not address Medicaid at all. There's been some noises about doing more with Medicaid in this next bill, but there's no sign that anything of the sort has happened. The reason to focus on Medicaid, quite frankly, I mean, of course it insures tens and tens of millions of people. It's the biggest single insurer we've got at this point. It's up around 71, 72 million people. But the biggest single reason is that, at least in theory, Medicaid can rush money to where it's needed. It's insurance, and so it pays claims, and it can push money to providers who are having to provide care much faster than, say, getting a loan and having a loan processed. And one of the things that's pending, nothing has happened yet, is some revisions in Medicaid that would allow it to be much better at pushing money out the door. From a beneficiary point of view, of course, Medicaid is irreplaceable. It's designed for poor people. There need not be any premiums, although some states charge modest premiums. Cost sharing is nominal. And most importantly, you can enroll when you need health care. There's no special enrollment periods or annual open enrollment periods. You just go apply for Medicaid. And in states that honor it, and some states have waived it at this point, your Medicaid coverage can begin retroactively. So it can pick up bills that you incurred up to 3 months prior to the application, if you were eligible back then and just hadn't applied, which is really important for people who have catastrophic illnesses and weren't able to apply at a previous point. So let's go through what we have now in Medicaid that we didn't before. A big change is this temporary hike in what's called the federal medical assistance percentage. It's the amount of money under a formula that states get from the federal government each time they spend money. So the state spends $1, it gets back anywhere from 50 to 75 cents. That's called the state-specific match. There are special parts of federal funding that are just fixed. I mean, for example, if you expanded Medicaid back under the Affordable Care Act, your federal financial rate is 90% for those adults. But the special FMAP is for those expenditures that are at the normal FMAP rate. But if you want the money, you cannot reduce your eligibility rules. You cannot restrict what's called the standards and methodologies that you use to calculate eligibility. So, for example, we make you apply in person. That would be an application standard or methodology. Obviously, that's not true anymore. It used to be in the old days. There were a lot of standards and methodologies, but there are ways that states can restrict eligibility, even though they have sort of a nominally high eligibility level, by making it harder to get through the enrollment or eligibility determination process. They can't do that during the pandemic period. They have to provide continuous eligibility. So if people were on Medicaid on January 1 even if they lose coverage or otherwise would lose coverage because the coverage is being redetermined, they have to remain on the program. And people who come on after January 1 during the pandemic period similarly have to remain on the program. So it's federal continuous eligibility. There can't be any increase in premiums. If it was a state that charged premiums, it can't hike premiums. If it never charged premiums, it can't impose a premium for the first time. And there can't be cost sharing for treatment. If you attach cost sharing to hospital visits, say use of emergency care at hospitals, you can't impose those copays during the epidemic, and you can't reduce your benefits. So it's really designed to take a snapshot of state Medicaid programs as they existed on January 1 and say, don't make any changes that disadvantage beneficiaries, and will increase your federal payments by 6.2 percentage points, which is sounds like not a lot, but it's actually worth a good deal to states. There was a new state option for the uninsured. It's an important step forward. It's the first time that we see an option just to cover uninsured people for this one tiny slice. The closest we've come is tuberculosis treatment. That's been an option for many years. Women can be covered for breast, and men for breast and cervical cancer in the case of women, treatment if they had no insurance. So this is sort of builds on those precedents, but it's just for testing. The hope was that Congress would go back and expand this to include treatment. That does not look like it's happening. Maybe we'll talk a little bit about what the administration is doing in lieu of treatment, which is troubling, quite frankly. It's opposed the treatment expansion in favor of a uncompensated care pool approach. On emergency Medicaid, Congress has unfortunately not taken a step that a lot of people urged, which was to clarify that anything that's COVID related is an emergency. This is important because, of course, people who are not legally present in the U.S. can, if they are otherwise eligible, get Medicaid for emergencies. And so it would have been a good thing to clarify that anything that's COVID related is an emergency. That did not happen. And so those are sort of the big changes. A hike in the FMAP on the condition that you don't make any cuts, an uninsured option, coverage of testing for everybody without any cost sharing. So if it was a state that was charging for physician diagnostic visits or for lab tests, they can't do that during the pandemic. And if they take this money, of course, they can't charge cost sharing for the treatment if they want the enhancement. What didn't happen? Well, in addition to, of course, Medicaid treatment expansion, one of the things that also hasn't happened is that the Trump administration has refused to open up a special enrollment period for people whose income at least makes it up to the threshold for marketplace coverage, which is 139% of the federal poverty level, basically. 138% is the cutoff for Medicaid. And for them, it would have been a good thing to have a public health emergency related special enrollment period. The administration refused to do that. For people who lose job-based health insurance, that is a special enrollment period. If you lose health insurance, you can then go into the marketplace, assuming you qualify. But if you simply lose a job that didn't have health insurance, but you realize now you better get some health insurance, you cannot. That's not a special enrollment period. In lieu of that, the administration has promised to take the uncompensated care funding that's going to hospitals, which they need, or the big fund, which they need to cover a lot of their upfront costs of acquiring equipment, acquiring services, acquiring masks and gowns and supplies, and building new sites and hiring extra staff. I mean, all the costs that go with restructuring the hospital to deal with this crisis. And the administration has said it would set aside some of the money for direct payment of uncompensated care, sort of an old-time uncompensated care pool. So far, there's literally no paper explaining this pool. There's a general website that says we're giving out money. There's one requirement that if you take money, you can't bill patients for services that were covered by the money. But that is to say that that's not a program is the understatement of the year. For example, there is no requirement that hospitals tell anybody in their service areas that this program is available to them. There is no requirement that notices be prominently posted in accessible languages in the service area. There is no requirement that people be given an opportunity to apply for financial assistance. There is no requirement that hospitals make some sort of simple eligibility determination. There is no requirement that hospitals keep track of everybody whose care was paid for with this funding, so that later on when the bills start coming, the patients have evidence that they were claimed as essentially, claimed as an expense by the hospital on the fund. There are no clear requirements about how much the hospitals can bill the fund for their services. So, you provide Mrs. Brown with services, which is fine. It's not clear to me that there's any place that says, and when you bill the fund, you can only bill the fund at the Medicare payment rate. You get a hospital that wants to sort of eat down its money and bills at the charge rate. So these very elementary safeguards that one would expect to see in a program that is supposed to help patients who need COVID care, at least hospital-based COVID care, from an administration that has absolutely opposed every effort to extend insurance to them, opposed the special enrollment period, opposed the Medicaid expansion to cover treatment. And now that it has proclaimed that it's going to implement this uncompensated care program, has done nothing, in fact, to make the program transparent or available to the people who need it. So the situation is, it's like everything else, we're sort of lurching along. The one other thing I might point out, of course, it's self-evident, I'm sure, to most of the callers on the line, but the worst problem of all may be in the 14 non-expansion states. I was trying to do some quick math. As Indy pointed out, the unemployment benefits count toward the Medicaid eligibility determination. $600 weekly payment does not. And in the non-expansion states, I think we may be facing a paradox as follows. In Texas, the average unemployment benefit will put you well over that state cutoff for parents. Single adults out of the picture entirely, but some parents might qualify. I'm getting an okay. Parents might qualify, but as they are probably too much, given where Texas sets its eligibility standard, which is 20% of poverty. But because the $600 per week supplement does not count, you have no way of reaching what in Texas is the 100% of poverty threshold to get into the marketplace. So you can't get Medicaid because your unemployment benefits are too high. But you can't get into the marketplace because your income, even if you add it in, your income without adding in the $600 a week is way below the federal poverty level. There are some number of people caught in this amazing paradox, Congress, of course, was being kind in not counting the $600 a week for benefits, but it didn't register on people that for some benefits, it actually helps to count the $600 a week. So why don't I stop there?
Hi, everybody. I'm back, and I am going to just start with questions. We've had a bunch come in, and I have a bunch of my own. And I actually want to start with one of my own for Sarah, which is, do we have a sense yet of how many people are applying for Medicaid, and if they are receiving it, or where they are in the process, or are they temporarily uninsured because they're in transition? What are we seeing out there, and what data points do we have?
Right, that's a really good question. We don't really know at this point. I have not seen any early enrollment numbers. I'm sure they're going to start coming in a couple of weeks now. The states report monthly, so we should be getting March coming in pretty soon. What I do know is that one organization has attempted to do some projection. And the Medicaid enrollment projections were absolutely eye-popping. We're at about 70 million beneficiaries today, and they did, what is normal in these projections, sort of a low, medium point, and high. Their high projection was well over 90 million on the program, because, of course, in the expansion states, the program is, as it should be, wide open to lower wage workers who never had any job-based insurance. It's responding exactly the way the safety net is supposed to respond. It's open, and they can come in and they can apply. And so in places like New York, California, Minnesota, Ohio, Maryland, the whole Eastern Seaboard, every place but the historic South and some states in the Midwest, the program will do just what Medicaid was designed to do, which is to provide insurance to people who need it, and to provide it fast, and to provide it with very little in the way of cost sharing. And the numbers will simply be a measure of just how poor, how much this has impoverished and harmed people, this whole pandemic.
Okay. Thank you for that. Indy, there's a question you said you wanted to take. I'll read it out loud. And it's a two-parter. It goes, so you'd be better off as a low-income worker to be non-essential. That's $600 a week, regardless of what you would qualify for under unemployment insurance, could be more than their regular paychecks. And I'm not sure what the question is there, but then the second part is, what about the idea of a supplement like hazardous duty pay, which Governor Cuomo has floated, but I'm not sure who he has suggested would be covered.
Thanks, Helene, and yes, thanks for this question from Nishu. So basically, Congress wanted to achieve 100% wage replacement rates for workers who lost their jobs because of COVID-19. In fact, states have such antiquated unemployment insurance administration systems and information technology infrastructure that they indicated it would take them around 5 months to implement 100% wage replacement for every worker. Instead, what Congress did, which is entirely reasonable and arguably quite sound under the circumstances, is a flat $600 weekly unemployment insurance benefit increase that, when taken together with the typical unemployment insurance benefit, would make the typical worker whole. That means, in fact, that many people with very low pay would have more income coming in through this additional pandemic unemployment compensation of $600 a week and unemployment insurance, should they get it, or pandemic unemployment assistance, should they get it. A couple of just key notes. One, they will, if they were getting any support from their employer for health coverage or other benefits, that's going to be gone by and large. And that can be very costly, as we know, especially family health premiums that they may have to purchase, assuming they're not eligible for Medicaid, can be costly. If you are eligible for Medicaid, of course, as Sarah noted, cost sharing typically minimal or non-existent. But there will be a loss in coverage continuity regardless. Secondly, employers in most states have the option of doing what's called work sharing, where they could reduce hours, depending on the state, 10 to 60%, and pay partial and have partial employment insurance benefits paid to their workers to help make up the difference. And those workers also get the $600 weekly unemployment insurance benefit increase. So they would be much better off, and it would be easier for employers to come back, obviously, as physical distancing needs reduce over time. So there is an incentive, nevertheless, to stay attached and keep workers attached to their job. As far as being designated essential versus non-essential, there are situations in which being designated essential can reduce some of your access to benefits because of, for example, the Department of Labor's interpretation of the paid leave provisions in Family First Coronavirus Response Act, which give employers a lot of leeway there. On the flip side, essential workers, as noted here, could be eligible for extra support if lawmakers enacted it, and Senate Democrats certainly proposed it for this upcoming sort of COVID 3.5 package, but it hasn't moved forward. And often you get more protection in other ways, including literally more access to personal protective equipment. Not that I'm saying any of that is where it needs to be. So I think we do have to look at all these programs holistically and think about how they interact. For example, we're thinking a lot about childcare providers and workers and what their options are, assuming that some of the SBA programs, including Paycheck Protection Program and Economic Injury Disaster Loan Program, are refilled and reformed in the next bill. But I think there's a case to be made for hazard pay, as you indicates here.
Okay. And my next question back to Sarah. Under the Emergency Medical Treatment Act, can hospitals refuse to care for people with COVID symptoms? If so, which groups of people and under what conditions? And how are patients considered stabilized and let go? And I would add here just a comment of my own, which is in New York, we're starting to see a few horror stories of people who were released from the hospital and then subsequently got either more ill or either unfortunately died at home. So I would throw that in as well as part of this question.
Very good question. I think the caller or the chatter is referring to EMTALA, the Emergency Medical Treatment and Labor Act. This, of course, is a 35-year-old law that imposes an obligation on all Medicare participating hospitals, so that's virtually all hospitals in the United States, with emergency departments, to screen people who come to the hospital, that's the phrase, seeking help for what they perceive to be an emergency medical condition, and then an obligation to stabilize the patient if the patient is found to have an emergency medical condition. It gets a little tricky during public health emergencies because the federal law actually gives the Secretary of HHS leeway, which the Secretary has done, to suspend the enforcement of the EMTALA obligations. The obligations remain on the books, but they don't get enforced, having to do with screening and stabilization. And the reason, I mean, there's in theory a reason for doing that, and that is where you have a public health emergency that requires that you direct all patients exhibiting certain symptoms to certain hospitals. Unfortunately, if the person is being brought in an ambulance and everybody's operating under 1135 authority, as this special authority is known, the ambulance might be diverted before it ever arrives at a hospital, to a hospital that's one of the designated hospitals. But of course, that's not how a lot of people get to emergency departments. They just come to emergency departments. Here at GW, one of the reasons why our emergency department is so popular is we're on a subway line. People ride the subway to emergency care. It happens everywhere. And hospitals actually may be able to put themselves on what's called diversion status. I mean, the vast majority of hospitals would not, unless they are literally so full they just can't take anybody. So EMTALA is there, but it's rocky during these kinds of extraordinary circumstances. When it comes to stabilization, there is no flat test. It's not like the screening test, where if somebody comes and requests a screen, they have to screen, and they have to screen doing whatever they customarily do for, say, someone with certain symptoms during a screen. They can't give you half a screen. With stabilization, the standard is much mushier. It is one of these legal speak standards of there's a reasonable probability that there will be no material deterioration, and the question of reasonable probability turns on objective medical evidence. And so you get into a he said, she said kind of situation. One of the complications in pursuing a claim against a hospital, because the private claims remain, the federal enforcement does not, but the private claims, I suppose, remain. But one of the problems is that, as I understand this condition, people can be discharged seemingly stable and within a matter of hours deteriorate to the point of death. And so one of the issues would be, did the hospital reasonably know that this was one of the few cases where a seemingly stable person whose symptoms were under control, who would probably be safer not being at the hospital and not super exposed, was left home, and nobody foresaw this rapid, complete deterioration. So unfortunately, and that's why the question is such a good one, not just because of the protections, but because you can see that for certain kinds of situations, even important, protections is as strong as EMTALA, it's a very strong law, begin to sort of break down under the weight of the emergency and hospital capacity and the realities of operating in the fog of a pandemic.
Okay, thank you for that. That explains a lot. Next question, again, is for Indy. One of the underlying infrastructure inequities here has to do with, sorry, one second here, I lost the question here, one sec. Has to do with how the stimulus money is allocated. The PPP funds, that's the payroll protection situation, were allocated by private banks who held much discretion on how these funds were distributed. We are starting to hear about how a disproportionate share went to larger, often more resilient among those qualifying as small businesses. And I have heard anecdotally of delays in processing applications of more vulnerable organizations, not-for-profits in particular. Will we ever learn that trickle down does not work, and that regulation is required to make sure resources go where they are most needed? Again, who loses the most when power is in the hands of the for-profit banks? And I would just throw in a third question there, which is, at what point, if any, will the government be forced to reveal who did exactly get these loans and who did not?
Yeah, that's a great set of questions, Deborah and Elaine. First, I worked on the U.S. House Committee on Ways and Means staff immediately before, during, and after the financial crisis in 2008. And it is definitely painful to see, as in this example, in many cases, we are repeating some of the same mistakes. I think one of the fundamental reasons why is that if we don't fix something in a more structural way during or just in the aftermath of a crisis, we'll come back and do what is the easiest, fastest thing to do. And a lot will obviously depend on the composition of Congress and who's in the White House. So I've worked a lot on more automatic, forward-thinking policies that would help avoid some of these problems. I mean, if you can hear some of the extraordinary things that Sarah was sharing about Medicaid and health, it just shows that in many ways that we don't design great policies right at the beginning of a crisis. And so I hope that we learn from our mistakes. And I will say that I've talked to a lot of folks who've had similar stories. The Paycheck Protection Program was absolutely sort of not well targeted and designed, especially to help people who were struggling the most, as folks have seen. And it is a general sort of challenge we face in this country, that it's easier for the Federal Reserve Bank in an instant to give transfer huge sums of money to keep markets liquid and promote sort of the financial institutions, private financial institutions in this country, than it is to even send a check to a household. I mean, it is incredibly difficult in this country to even do that. The social infrastructure that we needed even before this crisis was obviously not there, and it's incredibly ill-equipped now. I'll just say that there have been a lot of recognition of the failure and shortcomings of the Paycheck Protection Program. And there have been other proposals out there. I'm unfortunately not optimistic that the next bill you see will address the challenge, in particular of banks being sort of the middlemen here. I'll share an article by Jordan Weissman of Slate. I don't think I'm quoted in there, but I talked to him extensively beforehand that talks about an alternative. I mean, these are things that the government is capable of potentially doing directly, more efficiently, and more effectively in some cases.
What, if you could just summarize for a quick second, what is that alternative that the article suggested?
Well, yeah, absolutely. So essentially, the question that Deborah raised here about going to banks, hits upon a number of problems. I mean, a major one is that banks are only loaning to people they already know. Sophisticated accountants are going out of their way to help their clients. Sorry, I realized my video had stopped. Apologies. And so there's a complete mismatch. I think, Elaine, you asked about when will we know who's getting the loans. We do know at least some of it already, including by industries. And there's no real alignment between hardship and the industries getting the money. So, an alternative could be to just have a larger agency than the SBA, as Jordan proposes there. The SBA just can't handle it if they're the ones who are going to run it, because it's not a large agency. So you could have the Treasury Department sort of literally manage the aid, and you could, even do it directly. There's no real reason why they couldn't. I mean, you can always say, oh, we haven't done it before, but nobody had done what we just did before. And again, if you can pick up on some of what Sarah said, the amount of guidance and instruction and memos that has to come out is just always behind. So the more you have intermediaries, the more they're awaiting the federal government to make decisions to interpret these loans. So I think there is a case to be made that the government could, literally provide them directly.
Okay. Thank you for that. Okay. Next question. I'm going to throw this open to both of you, actually. Is there a way homeless people might receive stimulus checks through an authorized representative, like a shelter or local agency?
I could say something.
Okay.
I don't. Yeah. So they're going to be eligible if they have a valid SSN, which by and large they will. The IRS hasn't prioritized this, but IRS and Treasury are going to create, in theory, minimal filing that would have to be done. So they would need help probably getting to a computer. And I don't mean to make any of this sound like it's ideal or simple, but the goal is to make it as simple as possible to file. And then a check is going to have to be made if they don't have a sort of mailed, if they don't have a bank account. Then there's a question of what to do with that check, obviously, to convert it to money. So, an alternative I'll just float that some of us had suggested was using something like the disaster SNAP and the overall EBT system, electronic benefit transfer system, which some states indicated within 2 weeks they could get money on. The government does have the option of using the Direct Express debit cards that's used sometimes by the Social Security Administration to also load up money. They're fairly minimal fees. You can potentially use it with no fees. I think they're provided by MasterCard in an arrangement with the government, but MasterCard would benefit, of course, off the fees potentially, but initially they're a reasonable product. So that's another option for folks who are thinking about further cash assistance going out to push for that. We have a fact sheet with the National Women's Law Center that briefly touches on how that could be an option in a more extensive memo.
Okay.
Well.
Okay, great. Thank you for that. Next question, Sarah. And I'm going to ask if you can try to keep this to 2 minutes so we can get 1 or 2 more questions in, because we're coming up. We have 5 minutes left here, and I have a bunch of questions still. What is your interpretation of emergency Medicaid as our best route to covering immigrant people left out of coverage provisions such as those under the 5-year bar and the undocumented? Several states are using clarifications to ensure access to testing and treatment. I would just simply add as an editorializing comment, much the way infectious diseases and viruses don't know about your health insurance status, I don't believe they know about your immigration status either. So there are issues here that are important that need to be addressed.
Just quickly, I would say that Congress might have made the clarification. It didn't. I can't think of anything in federal Medicaid law that would prevent a state from treating all claims related to COVID for testing, treatment, recovery, not recovery maybe, but testing and treatment, certainly emergency.
Okay. And last question we have is about another one about the payroll protection program, which I think we've all discovered as something of a hot wire issue, as I've discovered in my work too. Due to racial wealth disparities caused by historical policies, people of color, especially single women, who have less than a penny of wealth compared to even single white women, have no way to cushion the blow of lack of income or loss to their business. And their being last in line for PPP will so far push them under. Is there any proposal or opportunity out there that takes this need into account?
Well, I'll say a little bit, and I don't know if Elaine or Sarah, you want to add anything to it, but that's sort of a very concise and more than reasonable description of a challenge that the country face. Before this crisis even, there are proposals to essentially use credit unions and others more. Again, you still have a sort of middle person. There are proposals to base the aid on revenue loss. So I don't know if folks know, but the Paycheck Protection Program in particular actually isn't even based on revenue loss. You don't have to have lost a penny. It's based on a sort of uncertain economic conditions and that arguing for the money. Of course, the vast majority of businesses are experiencing revenue losses, but not all. And there's also, ideas that would encourage more money going sort of in a more targeted way for individual assistance. The more we expand unemployment insurance, one of the tragedies of unemployment insurance, which I've worked on for almost 15 years, is that it actually disproportionately helps more middle and higher income folks. It leaves out a lot of folks who have lower incomes. Pandemic unemployment assistance might help with some of the gap, but it has been still fairly narrowly construed. The congressional pressure, I want folks to appreciate that public and political pressure can help improve the administration and implementation and interpretation of these laws, and it certainly has in the case of pandemic unemployment assistance, where the Department of Labor just released a letter responding to, frankly, many Senate Democrats, and it basically agreeing to a much more expansive program they initially seemed that they were wanting to agree to under the law. But even that's going to leave out, and this is another big worry of mine, millions of youth and young adults, especially who are exiting school, but also lots of people, whatever their age, exiting prison. And so there needs to be a way to provide relief to them as well. And the House proposal before the CARES Act was enacted had a job entrant compensation program. I hope and would not be surprised if we see a version of that again in the 4th COVID response package from the House.
Okay, thank you both. I'm going to turn this over to Bill for our conclusion, but I want to just thank both Sarah and Indy for being such great panelists and for all the listeners for asking
Thank
such
you for
amazing
having us.
questions. Bill, take it away to finish.
Just let me echo that, Helene, to you and Sarah and Indy. Please circle on your calendars May 5th for our next virtual roundtable focusing on people with disabilities. I want to thank the members who have been contributing to the Academy. It's because of your dues and your contributions we're able to do things like this. So please continue to support us. And most importantly, between now and our next session, please stay safe and healthy. Some of you are in areas that have not yet seen the worst. So please be well and stay safe. Thanks to all of you again. Bye-bye.
Thank you.
Bye-bye. Thank you.